Our today's topic is primary open-angle glaucoma Part 3. Signs. 1. IOP. The International Society for Geographical and Epidemiological Ophthalmology has published a consensus definition for POG. This definition does not include IOP, i.e. POG is diagnosed based on signs of glaucomatous optic neuropathy regardless of the level of IOP. Patients can be classified as normal tension glaucoma (NTG) or high tension glaucoma (HTG) based on the IOP. Sometimes an IOP spike may be missed in a clinical setting. In these cases, if HTG is suspected, measurement of IOP at hourly intervals throughout the day, beginning in the early morning, may be indicated. This is termed phasing. If a patient has all the features of POG but consistently normal IOPs less than or equal to 21 mm of mercury, this is considered NTG, discussed further in another section. 2. Anterior chamber angle. By definition, the anterior chamber angle of POG patients is open. The Van Herk test provides an estimate of anterior chamber depth peripherally and reveals an iridocorneal distance of greater than 25% of corneal thickness. Gonioscopy is essential to make the diagnosis of POG and should be performed on the initial visit. Various classification systems have been described to assess the extent of an open angle. Gonioscopy helps to differentiate POG from secondary open-angle glaucomas such as pigment dispersion in pigmentary glaucoma or neovascularization of the angle in neovascular glaucoma. 3. Optic disc. Optic disc changes seen on clinical examination of patients with POG include high cup-disc ratio. Cup-disc ratio asymmetry between eyes usually considered significant if greater than 0.2. Vertical elongation of cup. Focal neuroretinal rim thinning or notching. Vessel bayoneting. Beta zone parapupillary atrophy. Disc hemorrhage. Clinical diagnosis. Advanced POG is a relatively clinical diagnosis. Patients will have undisputable characteristic optic nerve damage and restricted visual fields. However, visual function loss from POG is irreversible, therefore, it is critical to diagnose this disease as early as possible and prevent further loss of vision. Diagnosis of early POG is more difficult. Optic disc changes or visual field abnormalities may be more equivocal. When the evidence for POG is not compelling enough to commence therapy, the patient is referred to as a glaucoma suspect and reviewed regularly to watch for any signs of progression. An experienced clinician is able to assess clinical examination findings in conjunction with investigation results and make a decision as to the diagnosis. Clinical findings corresponding with investigative findings add weight to the diagnosis of POG. For example, Figure 1 shows the left optic disc of a patient, and Figure 3 shows the left visual field of the same patient. The thinning of the superior neuroretinal rim of the optic disc corresponds well with the dense inferior arcuate scotoma in the visual field. This provides strong evidence for glaucoma. Another important characteristic of POG is that it is a progressive disease. If optic disc appearances and visual field changes are static on no therapy, this would count against a diagnosis of glaucoma. Diagnostic procedures. 1. Optic disc. Diagnostic procedures such as HRT, October and GDX are useful objective adjuncts to clinical optic disc assessment. Quantitative measures such as neuroretinal rim area or volume and retinal nerve fiber layer thickness are useful for monitoring and assessing progression. Also, when compared with normal population values, they may give some indication of diagnosis, e.g. Moorfield's regression analysis for HRT. This is discussed in more detail in the section Optic nerve and retinal nerve fiber imaging. 2. Visual field. Features of visual field defects, detected on automated threshold perimetry, that are characteristic of POG include localized defects respecting the horizontal meridian, nasal step, arcuate scotoma, generalized depression, abnormal glaucoma hemifield test. Differential diagnosis. Differential diagnoses to consider include ocular hypertension, elevated IOP but no definite signs of glaucomatous optic neuropathy, normal tension glaucoma, all the features of POG but IOP always measured within normal limits, Primary angle closure glaucoma, narrow drainage angle on gonioscopy. Pigment dispersion glaucoma, Krukenberg spindle, iris transillumination, heavily pigmented angle in all 360 degrees. Pseudoexfoliation glaucoma, pseudoexfoliative material seen on pupil margin and lens. Steroid-induced glaucoma, history of topical or systemic steroid usage. Posner-Schlossman syndrome, mild inflammation, unilateral. Physiological cupping, normal large optic disc with large cup-disc ratio, should be symmetric. Myopia, optic discs can be very difficult to assess, and may be associated visual field defects which are not generally progressive.